with that, I would like to once again welcome everyone to Businesses for Health Private Sector Monthly Meeting. We have Dr. Maria Moguna from POMGEN, and I'm going to hand over to my colleague, Dr. Vincent Piakalia over at Oil Search to introduce his friend who has made this week's interesting presentation possible. Thank you very much for your time, Dr. Maria. And Vincent, if you'd like to open your mic, and welcome Dr. Maria Moguna from POMGEN.
Thanks, Anne. Thanks, everybody. It's my extreme pleasure to introduce my friend and my colleague, Maria. I think a lot has been said and heard about the challenges our hospitals are facing with regard to caring for COVID patients. So I'm really happy that Maria has made the time. And no doubt for her as an anaesthetist working in our biggest hospital, Port Moresby General, there will be some valuable information that she can share, especially with the challenges they are facing with caring for critically ill COVID patients. So without further ado, Maria, thank you very much, and I leave the floor with you.
Just before you start, Maria, can I ask you all to check that you are muted rather than your background sound? Thank you, Dr. Maria.
Thank you, Dr. Anne. Dr. Vince, it's a pleasure to be with you this afternoon. We're honored to be invited as a representative from the POMGEN, working as an anesthetist, and of course looking after the COVID ICU patients here at Port Moresby General Hospital. So for those of us who aren't quite familiar with the job that we do, we're general anesthetists. So what that means is that we look after, take care of critically ill patients in the ICUs, non-COVID plus the COVID. Come the COVID pandemic, we've also delegated ourselves there to look after such patients. In addition, we anesthetize patients during surgery, care for them, and right through to their recovery, either back to their wards or back to the ICU ward, whichever that they need to go through. So across the country, we're quite a young discipline specialty. There are about less than 30 of us as specialists practicing. We've managed to cover the whole 4 regions by as specialists, 4 specialists covered. And now with the pandemic, you'll hear that our team's quite on high demand, and unfortunately, the numbers do not really meet the requirements or the demand that's currently ongoing. So of the numbers, about 50% of us are located here in NCD, and almost about 10% is into private practice. Now, why do I have to elaborate on the numbers? Is one of our specialties in our discipline is that we ventilate critically ill patients. So the use of the mechanical ventilator can only be safely used by our specialty as anesthetists and no other. We know very well that the machine can either kill or save the patient. Therefore, we're very much needed in the areas of where patients need critical care, basically for respiratory support. I'll give an outline of what's happening here at the POMGEN, and I believe that's where your support or knowledge of what we're doing here is really needed in this talk. And I do appreciate the fact that there is interest in what we do here, and hopefully surely outline to you the challenges that we are facing, have been facing, are facing, and potentially will be facing should the numbers increase. I can give you statistics for about last month, which is September, so that's when the third surge was observed to have started. That would be in the second week of September. So on average admissions a day, I will go directly into the admissions. We're receiving patients from the private sector, from the clinics, urban clinics, say from General Hospital as well. Now, in a day, within these past 3 weeks and ongoing, on average, we're seeing like 30 to 40 patients who've been positive. So as of 8 o'clock this morning, our positivity rate has been 68%, which was 67 yesterday, and today is 68%. So you can imagine the numbers of patients coming in. So out of this 67%, we have categorized patients, from mild to moderate and then moderate, severe. Our bed capacity for the hospital is about 942. Out of these beds, the management made it possible that 126 would be designated for the COVID patients. So of these 126 beds, the ICU aspect of the care has been delegated about 6 to 9 beds. We're now caring for about uh, four critically ill patients, not ventilated. And they're all full, actually. The wards are full and now needing the patients' referrals to the aquatic center. So that's been opened on Friday last week. And thank you to the NGOs, DFAT, that have made that possible for us with their funding. So out of all the patients that we're looking after, like I said, we're caring for about 4 to 6 patients at any one time. Within the last month, in this surge, we've managed to ventilate about 2 patients of these 6, and the ward has been full the whole time. I mentioned that 6 beds of the 126 are for critically ill. We have a donga that's delegated for the moderate and severe critically ill COVID patients, which is a 19-bed capacity. So for this actually week, the demand for the admissions are so high that over the past 2 days, there have been no admissions. The reason being that the ward has been full. So no one's getting admitted out, no one's discharged. So other patients have been kept at other sites. That could be the emergency department, the tents, funded by the OSMET, the DFAT, and in every discipline in the hospital, they've allocated a certain number of beds to keep their mild and moderate patients. Only when patients are deteriorating, then we get them over to the isolation ward. Okay, we're now in the process of transferring all our COVID patients to one ward and transferring patients from Pmgh to the aquatic center. We're keeping only the severe cases and those that need to be mechanically ventilated. So we're hoping that by this weekend this will happen. So then you have reduced chances of cross infection, cross transmission of the disease in the ward, specifically in those wards that have delegated their beds to look after their mild and moderate cases. So I think we'll move on to the challenges that we're now facing in the ward. Basically, I'll go point by point. In the isolation ward, we have patients who are moderate and severe and needing extremely high flows of oxygen. So these are patients who are literally hungry for oxygen. You know, now by percentage, the age group that we're seeing, the prime age group from say 20 to the 40, 45 and 50 years old, so 50% of our admissions are within that age group. And uh, ages beyond that, more than 50% of them come in with comorbidities. So we're talking about like diabetes and complications such as hypertension, mainly hypertension, or even those that have, previous history of a stroke. So one of our latest admissions coming in with the comorbidity of diabetes has we lost her about 2 weeks ago. Was also one of our nursing officers. It was a very sad story. And on top of that, I think one of the high risk patients would be those who are obese. Yeah, BMI of more than say 30. These are patients who tend to demand for oxygen maybe triple times more than their uh, normal consumption. So what happens if I decide to or I administer a patient for mechanical ventilation? How does that affect our consumption of oxygen? So with our calculations currently in the isolation ward, for one patient to get ventilated in a day would require about 5 to 7 size G oxygen cylinders. So that's quite a high demand. If the surge, if the numbers keep increasing, so from 4, say we have 10 in a day needing oxygen for while mechanically ventilated. So you'd almost require 150 to 170 oxygen size G cylinders in a day. And of course, taking into account those patients who are treated on just single sourced oxygen. And when I say single source, meaning just patients on either nasal prong or non-rebreather bag face mask. So such patients, we've noted that in a day, if one patient is on single source, would require about 2 to 3 size G oxygen cylinders. So it is happening around the country. We're seeing the trend in Goroka. They're actually literally flying in, cylinders from Leh. We're fortunate enough to have supply for now, but then what happens, here on after, if there's a need for more oxygen. Another challenge for us right now is the availability of PPEs. During the first and second surges, we, of course, had shortages of PPEs, and so we had to improvise with what we had to basically protect ourselves from acquiring the infection. Currently, we have adequate PPEs available, but in the weeks to come, as the numbers increase, we will surely need need constant sustain the supply of PPE. Another challenge we have come with the PPEs. We would need alcohol sanitizers, and so the hospital, under the NGO support, has managed to be able to provide its own, produce our own alcohol sanitizers. Now, we're able to do that for now. I think this week we produced about 600 bottles, 250 ml bottles, and that's been circulated throughout the hospital for use. The challenge in sustaining this process or this service is the availability of the bottles, plastic containers, and we would need 200 ml container bottles to store the hand sanitizers in. If I can go back to, sorry, the third consumable that we would need as well would be disposable gloves. And in a ward, in a general ward, we're using like 3 to 4 boxes. So there'll be like 100 pieces in a box. With the pandemic, the need has gone up to 3 to 4 boxes a day. Whereas in the isolation ward, we would be consuming 3 to 4 times this number. I'll go back to statistics within the last.
Excuse me, Maria, could you just
yes?
repeat what was that fourth thing that you said after alcohol hand sanitizer? You said a fourth thing and I just missed exactly what you said.
Yeah, so I was referring to the disposable gloves.
Gloves. Thank you.
Yes, disposable gloves. Yeah, so we tend to also run short of this. But when we do, if there are available steroid gloves, then we improvise using that as disposable. So I can go back to our statistics again. By mortality rate, I think we're doing pretty much okay to the isolation ward overall, with including the non-ICU patients. So for the last month, we've admitted about 61 patients, and our death rate out of the 61 has been like 9.8%. So I think overall, that's, the number looks generally good. That's a mixture of the ICU patients plus the medical patients. Now, when we take the medical patients, exclude them from the ICU patients, so we've looked after almost 6 severe cases. Sorry, eight severe cases. We've put about 6 on non-invasive ventilation, and our success rate was near to almost 0% almost. So mortality rate is quite high when it gets to the severe case. By the time they're presented to us with ARDS on board. And we've noticed the length of stay in the ward is less than 2 weeks, despite the medical treatment. The ivermectin started on. We've included, our medical team has included ivermectin into our SOP currently. So that's been started. Apart from the steroids and the anticoagulant that we're using is Flexane on the patients who are indicated. Those who are contraindicated, we don't start the anticoagulant on. Okay. How about referrals? Are we receiving referrals from outside of NCD, outside of Port Moresby General Hospital? So yes, we are. In the past 3 weeks, a total of 3 referrals, 2 from the Western Province, one of which was an employee of OTNL. I think one of the senior executive members, unfortunately had, arrested on the tarmac. So everything was stopped and the body was brought back to the hospital. We've received referrals from Western Province and the Gulf Province, and that has, I think, seeing for, we may say, well, that's not, heavy, but on the ground, it does add additional burden to what we're doing already. The beds are full. We're sending mild patients home to home isolate and only looking after moderate and severe cases. So I think what should and need to be done is that hospitals, provincial hospitals, should be encouraged to look after their critically ill patients. And we're seeing this happening in the hospitals that don't have anesthetists working in there. So obviously there is a demand for our manpower to go out there. I think I've basically covered needs in my discussion as to what we're doing in the isolation ward. One of the big topics that's currently ongoing, has been ongoing since COVID or since its invention, is vaccination. We're struggling from our end as well to vaccinate our staff. To date, our staff vaccination status is about 27%. And of these, more than 90% are medical officers, and the nurses coverage rate is about 6%. The change that we're observing over the past few weeks with the statistics update, from our teams, and sharing the statistics to our individual specialties, that has affected, or let's say caused, an increase of our staff members, more specifically in the doctor numbers being willing to get vaccinated. And touching on the vaccination, so far, 100% of the patients admitted to the isolation ward and 100% of the deaths are patients who've been unvaccinated. So there is a real need to advocate for vaccination, be it AZ or Sinopharm or J&J, which is what we have available here. Even in the hospital, we set tents to have people get vaccinated. And including in the positivity rate is our staff members who are also getting infected while on the ground working. And most of this are coming from the nursing division, those of whom who have not been vaccinated. So we all know on social media, where we're reading that there are so many myths associated with getting vaccines, so that's causing fear in the people from being vaccinated, and the effect of this is as real as we're discussing right now in the hospital staff, which is causing a bit of resilience, if you can say, from nursing team or medical even medical doctors getting vaccinated. But like I said, with this surge and with statistics being shared to hospital staff, that has actually helped a lot in encouraging staff members to be vaccinated. So we're hoping to see this trend rise in the coming weeks. I'd like to just finally make a mention of maybe uh, some of the needs that we think you may help or assist with, some of which I have already mentioned. There are struggles like manpower, both the nursing team and the medical availability of medical officers. Um, Nationwide, if you could say, availability of anesthetists. I've mentioned already the need for a plastic bottle for filling in of our sanitizers, and we submit essentials, list of essentials to the management for which they tend to help where possible, and we're making do with what we have right now. I'll end off here by just informing us all that COVID is real. We see it every day in the wards, particularly those who are severe, critically ill. The hunger for oxygen is real, secondary to the lung pathology with the onset of ARDS, and mortality rates increased by the fact that patients you do have comorbidities such as diabetes, hypertension. And I think the way forward would be advocating for vaccination and also advocating for nuclear passing to be maintained always, which in our population would be, we're seeing it every day as well. In our population, would be quite difficult to do that in public places. Thank you.
Thank you very much, Dr. Moguna. I'm monitoring the questions here, so I'll just go back as I've been recording them. Once again, thank you, and thank you for your audience. I've kept you all on mute so that we don't hear too many dogs or babies in the background. First of all, someone asked if you've had any serious cases in the hospital of people under the age of 18.
Right. So within these 3 weeks, the youngest admission we've had was less than a year old, and there were 2 children actually, and they both got discharged, transferred out from the isolation. So I can only speak from where I'm at. Now there are deaths from ED as well as from the OSMAT tents and from the other wards, specifically in the adult medical wards. We haven't had pediatric deaths in this stage.
Okay, thank you. The other question that I have been asked is about the contraindications to vaccination, and I know, and I'm very mindful that the COVID-19.gov.pg website has a lot of information about this. But can I hear you say what would preclude somebody from getting vaccinated? Is there any reason not to be vaccinated?
Yeah, a great question. So I'm a pro-vaccine. Yeah, we do have anti-vaxxers. We're vaccinating pregnant moms, people with comorbidities, and of all ages above adult age. Yeah, so I think 20, 20 and above. I'm not fully aware if there's pediatric or vaccines available for children here in PNG. I don't think so. But please, with people with comorbidities have all the more reason to go and get vaccinated. And pregnant moms as well. I have friends and colleagues who are pregnant, postnatal, have gone to get vaccinated. So please do.
Okay, you heard it from the experts. Please get vaccinated if you're pregnant. Please get vaccinated if you have comorbidities, because your risk of being seriously unwell or being admitted to intensive care is much higher. I also heard you say, Dr. Moguna, that 100% of patients that you see in ICU have been not vaccinated.
Correct. Absolutely correct. There has not been a vaccinated patient who's come under our care as yet in ICU critical.
Thank you. And I may be a few days behind on the statistics, but our colleague at the COVAX facility wanted to remind me that at the last situation report, 130,000 people had received their first dose of vaccine, but only 57,000 have had their second dose, which relates to another question that I just had. So it would seem that vaccines are not very effective at preventing serious disease unless you have had two. And I'll come back to the Johnson & Johnson, and Dr. Moguna, you might want to comment about that. But Sinopharm and AstraZeneca are two-dose vaccines. And to date, not very many people, less than a third, have had their second dose. Less than a third have had their second dose. So you won't get the 75% efficacy. Sorry, I've just got someone who's in the background there, so I'm going to have to mute you. Sorry, Debbie, I just have to mute you. Okay. Yeah, so only 57,000 people have had both of their doses of vaccination, which will get you up to about, on average, this is about a 75% efficacy at preventing serious disease and death. Okay. Dr. Moguna, the question that a lot of people get confused about is this idea about efficacy of vaccines. And I just said about 75% across the vaccines in efficacy after the required dose. Is that 75% against dying, 75% against getting infected at all, or 75% against the chance of being sick? Would you like to clarify those? My three guesses?
So numbers do vary. We go by WHO, what it provides for us. So what I understand is that if we're talking about 75% efficacy, so if it's there to protect that certain percentage to protect us from acquiring the disease, but then you have the 25% chance of still being able to get infected, yeah? And how much percentage? If the 25% chance where if I'm going to I have a 25% chance of getting infected. Now, how seriously will I get sick from the COVID? Yeah, is that the question?
Yes.
I understand. Yes. So I can, from the care to date, we've had 2 patients who've received their first doses only of the AZ. One was supposedly to have been referred to us from the Western Province, unfortunately passed away. And she'd had 1 dose of the AZ. and another was a young mom who's also had the first dose, unfortunately, passed away. So that's the picture we're seeing here in POMGEN. I cannot tell you, how serious the infection will be in a patient who's already vaccinated once and acquires the infection, and how serious, but that's the trend that I've known two patients who come in with severe COVID, but had only the first dose.
Okay, so thank you very much. So it's about being fully vaccinated. And again, just to reiterate, Dr. Moguna is saying those patients that she is seeing, many of them, particularly if they're older, have underlying health conditions which include diabetes, high blood pressure, and obesity, and other heart disease related things. Shahid, you asked me a number of questions. I hope I've covered them off. Please type in the chat. I have another question here. This person just missed hearing you. Dr. Moguna, has the hospital seen any fatalities amongst pregnant women with COVID-19? And could you also just clarify again on the capacity of the ICU ward? Thank you.
Okay, so with the first question, in this search, we've admitted 2 pregnant moms, and one was in the early second trimester, the other one almost going into her third trimester. These are also high risk group of patients with severe COVID, and I think from CDC, moms who are unvaccinated almost have like a 70% chance of mortality rate, yes, and very little chance of survival. And I've seen it here for those 2 moms we've actually lost. They came in with severe COVID and with no comorbidities.
Okay, so I think the answer there is that pregnancy in and of itself is a very high risk factor for serious or fatal case of COVID-19. Just going down the questions.
The second question was about the capacity.
Oh, sorry. Yes, ICU. Thank you.
Yeah, in the ICU. So it depends on what you mean by capacity, as in the beds or availability of the ventilators and the monitors and pumps that make up a room, which we call, critical care unit. So we'll try to provide as best as we can, and we have enough ventilators. We know, the states receive ventilators and purchase ventilators. I think one of the needs at the moment would be infusion pumps, and that would be either syringe infusion pumps or, infusion pumps directly hooked to the fluid, IV fluid. But we're making do, yes, with what we have been provided with.
Thank you. Dr. Moguna, I'm going to read you this question, and I was going to make a quick comment because it's more of a logic kind of consequence question.
Okay.
The question is about people who died from COVID-19 have underlying issues and complications, but do we have statistics or deaths caused by COVID-19 alone? In my interpretation of that question is that COVID-19, because we have so many comorbid conditions within the community and the population, there's no point in differentiating between a death from COVID-19 or a death with COVID-19 and high blood pressure. A person with high blood pressure may live well for the next 20, 30 or 40 years.
Yes.
So splitting the hairs on high blood pressure and COVID-19, if you are the breadwinner for your family, I think at this point of the game is almost a redundant question, with all due respect. The point is, if you do have other risk factors, you are more likely to be very, very sick and to die. Dr. Moguna is nodding with me.
Probably couldn't have said it better, yes.
Thank you very much. Shahid is asking me, are there sufficient stocks of systemic steroids at PMGH?
Right. Very good question. We do tend to run short of IV drugs, yes, and steroids would have to be one of them as well. We do have supply now, but there will be a need. There is a need for that. What we're using now is, in our protocol, is dexamethasone for adults or those with moderate severe COVID. Yeah. Thank you for asking.
Thank you. Okay, here's another quick question. Oh, sorry, long and complex question. We have the idea. Can you tell us what is the key ingredient in the vaccines that are involved in creating the mRNA vaccines? I don't know that Dr. Maguna's an immunologist who would like to get herself too involved in that, but go right ahead if you would like to.
I would advise for the team to please read up on that. I know it comprises, mRNA, but right down to the immunology, I would encourage the team to read on that. Even maybe to have a CME session on the composition of the different vaccines that we have.
How long before we will not have enough space in ICU?
Great question, because we actually already reached that level. The wards have been full. I think I've mentioned this earlier on in the talk. The wards have been full for the past 3 days. But of course, we're not sending, moderate patients home. Those who've been assessed to need oxygen therapy have been admitted to other wards apart from the ICU isolation ward.
I'm taking it from that you are already shuffling people in terms of priority and need.
Sure. We're currently on, thank you for bringing that up, Dr. Ann. So within this week and next week, we've scaled down on services, basically to reshuffle staff to the most needed areas, and also recruiting short-term staff members. And so hopefully after next week, then we'll go back to normal services.
Thank you.
Yeah.
There's another question here about vaccine hesitancy, and I am not going to ask you, unless you would really want to talk about why people don't want their vaccines. But I'm afraid I don't know the name of this person who's asked the question. But we have addressed this nearly every week for the last year, and my comment would be is to provide people with the capacity to get vaccinated as fast as possible, and that the best way to get people vaccinated is to drive them to the centre and hold their hand while they go in their door, and any time spent talking about vaccines much after that is time wasted, because you can help someone else to get in the vaccination clinic door. And we know that the Rita Flynn Centre and the Vision City Centre is working really efficiently, and it's about getting people to the door. So do you want to comment about hesitancy at all? We're reluctant to promote discussion about hesitancy because I believe it's about just getting the person there.
Yeah, you know, if something's there to help you save your life and you've made the choice not to take it, I mean, how do we reason with that? You know, we're seeing it, you know, right before our eyes that unvaccinated people are dying, those whom we are recording. And I haven't as yet managed a vaccinated patient in the ICU to date. So I believe vaccination is the way forward.
Any questions that I think can be addressed by an article on our website, I am very happy to post, so stay tuned after that. Thank you very much for your questions. Is anyone want to put their hand up? And Mary and the team are monitoring. Anyone who wants to ask a question quickly before we say thank you to Dr. Maria? It's always very hard to follow all of this. The last question, just quickly, is does the vaccine actually shield us from the virus? Would you like to comment on that?
Yeah, good question. So there's percentages. You know, different vaccines has the percentage of efficacy, and it's not 100%. I'm fully vaccinated. Maybe I need to get a booster, you know, J&J, but currently I'm fully vaccinated. With this, you know, 30 to 35% chance of me acquiring the infection, and I'm fully aware of that. And in our statistics of positivity, we have staff members who've been fully vaccinated, but have acquired the infection while in the care of the patient, and not one of them has come into the ICU ward. They're sent home for isolation and returned to the normal duties. Yeah.
I hope that answers your question. The vaccine is about preventing you from becoming seriously unwell. And the aim of the management of COVID is to have it become like a common cold, so people experience mild symptoms and do not get very sick and do not die. I am just going to quickly see if apparently there's great news today in that Pmgh will be able to produce its own oxygen. We look at that.
Yes.
That's fantastic news. And I see our friends at SP Brewery down there. I'm sure they have a lot of 200 ml plastic bottles that they may be able to share with you.
That is great.
I shall send Ed a reminder. Ed, if you're still there online, I'm sorry to put you under public pressure like that. And there's many notes here of thank you very much for your time, Dr. Maria. We appreciate the effort that you've put into being prepared for today. And we are very heartened with the number of people who are online to ask questions and have shown interest. I hope this has provided we've had over 100 people online this afternoon, and we know that these people represent that's 100 faces on the Zoom, and I'm aware that there are many offices that have more than one people tuned in. So your message has been heard loud and clear across Papua New Guinea and across the workplaces, many workplaces who represent many, many thousands of workers in Papua New Guinea. So I know we can't hold you any longer. Thank you ever so much for your time. Thank you to our friend Vincent for making sure that your friend was with us today. We rely in this world very much on the great friendships amongst the medical fraternity and the support that they have provided with us. So with that, please, we look forward to inviting you to a meeting about being able to book vaccinations at Rita Flynn, and we're trialling a system. Please follow us on Facebook to keep those announcements on the go. We're working as hard as we can with Dr. Stephen Yenny and the team at Rita Flynn to help make vaccinations as efficient and as fast as possible, so that you can take just an hour or two off work and get back to work as fast as possible. And may I sincerely hope none of you ever meet Dr. Maria Moguna.
Thank you very much, Dr. Anne. Thank you very much, Dr. Vince, for linking us up with your team here. May you all take care, and it's great to be a part of you in this afternoon's discussion. Thank you very much.
Thank you very much. Thank you very much, everyone, and we look forward to seeing you to our next meeting, and we'll be back on the first Thursday of next month, where I hope to link it with your activities in the most vulnerable amongst us, the immunocompromised people living with HIV, in time for World AIDS Day, in activities in your workplaces, and that you stand by for announcements and activities around vaccination service improvements across the NCD and across PNG in all of the provinces. So thanks everyone, take care, make sure you cover your cough, wash your hands, keep your hands off your face and maintain your social distance and get vaccinated. Thanks everyone.
Thanks Annie, thanks doctor.
Bye.
Thank you.
Thanks everyone.
Thank you, doctor.
Bye.
You're welcome. Bye.
How are you?
Thanks.
How